We'll move on to this ophthalmology part of this game changer session. And first, we're going to see it is this cataract. Okay, there are different types of cataract. If you see, there is this mature cataract, and before this, there will be this immature cataract. Immature cataract. You know, this immature cataract, what it will do, it will absorb the water, and it will absorb the water, and once this cataract or this lens absorb this water, what will happen? This lens will swell up. The lens will swell up and it will closes this anterior chamber. So this type of immature cataract will causes what? Will causes this type of glaucoma, which is known as phagomorphic glaucoma. Phagomorphic glaucoma. Okay, it causes phagomorphic glaucoma. Fine. Next, if you see, after this immature, it will become mature cataract. This will become mature cataract. Once it becomes this mature cataract, we need to do surgery and we need to remove it. Okay. Then once after this mature cataract, usually in rural Indias, they won't go for the surgery. They will lead to this type of cataract, which is known as hypermature cataract. Hypermature cataract. And this hypermature cataract can be of different types. One of them is in which the central nucleus of this lens, it will fall down. Okay, it will fall down. Okay, fall down. Okay, it will become like a gel, and this central nucleus will fall down. Okay, so this type of cataract or this type of hypermature cataract in which the center nucleus will fall down, it is known as what? It is known as Morgagnian cataract. And sometimes this lens will get ruptured, and this material can come and obstruct the flow of aqueous. So it will cause which type of glaucoma, guys? Will this same cause phagomorphic glaucoma? No, this will cause phagolytic glaucoma. So remember, this hypermature cataract like Morgagnian cataract will cause phagolytic glaucoma. Okay, and there is one more type of hypermature cataract in which the lens becomes sclerotic. So it is known as sclerotic cataract. And next, in mostly the questions they will describe, there is a patient who is presented with previously with a history of decrease in vision. Okay, decrease in vision, and also presence of seeing halos around him. Now, what happened is that now previously he used to use reading glasses for his near vision, but now he is able to read this newspaper or this books without the use of this eye glasses itself. So they will ask, what is the name of this type of cataract in which this phenomena happens, which is known as second sight phenomena happens. So which cataract? It will be the nuclear cataract. So in the case of nuclear cataract, if you see, this nucleus will become cataract. So the light cannot enter into the center. So the pupil will dilate. There will be this dilatation. Yeah, this is the dilatation of this pupil leading to this light rays to be entered. This nearby light rays will enter in this part, in this side. So this leads to this near vision to be clear. Okay. So there is an improvement of this near vision. It is known as second sight phenomena, which is seen in a case of nuclear cataract. Improvement of near vision. Fine. And then cortical cataract, mostly they will have this blindness, which is known as night blindness. Means on night we need more vision, right? So the pupil will dilate, but mostly this cortical cataract, it will be on the sides. They will be having the blindness over the night. Remember. And next, if around this posterior pole, if there is some kind of opacity is there, then we'll call them as posterior subcapsular cataract. Posterior subcapsular cataract. And remember, this posterior subcapsular cataract will cause us this maximum visual handicap. Okay, remember. And these are the few types of cataract you should know. Next, we'll know about this few other types of cataract based on their mechanism. For example, in the case of diabetes, you will see this posterior subcapsular cataract as well, and you will see one more cataract which is known as snowflake cataract. Next, if you are able to see this type of sunflower shaped cataract, it is seen in a case of Wilson's disease, and in a case of blunt injury, you will see this rosette shaped cataract. And next, in a case of myotonic dystrophy, you will see this type of Christmas tree cataract. You will see Christmas tree cataract in a case of myotonic dystrophy, snowflake cataract in a case of diabetes mellitus, and Wilson's disease, you will see this sunflower cataract, and rosette cataract in a case of blunt trauma to the eye. Okay? Then in a case of galactosemia, we know the deficiency it is this galactose 1-phosphate, galput deficiency, galactose 1-phosphate iodide transferase deficiency, and this leads to this oil drop cataract. Oil drop cataract, remember, fine. And next, in the case of Loeys syndrome, there is a syndrome which is known as Loeys syndrome. There is this cataract which is associated with this posterior lenticonus, means this posterior part of the lens will become more conical in shape. This is known as posterior lenticonus. And there are few drugs which causing this cataract, which include the steroids, ethambutol, anti-tuberculosis drugs, and this amiodarone. We studied, right? These potassium channel blockers, which is amiodarone. All of them, they will cause us this cataract. Fine. Then for this cataract, we need to do surgery, right? Previously, we need to do two types of surgery, including this extracapsular surgeries and intracapsular surgeries. Now, mostly we'll prefer, in a case of if the patient comes with intermediate and mature type of cataract, we'll do this phacoemulsification surgeries. And in a case of phacoemulsification surgeries, we know there is a probe which is known as phaco probe, and this phaco probe, it will use this ultrasound waves to break this lens. Okay, to break this lens. Fine. And for that, we'll make an incision with the blade which will be like this in a diagonal shape. It is known as keratome blade, with a keratome blade. So once you make an incision, then you will put a port. And we will enter in a Z manner. In a Z manner, you will enter, and then you will reach the anterior chamber, then into the lens. Once you reach into the lens, then you will need to stain the capsule of the lens. You will stain this capsule of the lens with a dye known as tryptan blue dye. And once you stain with this tryptan blue dye, you need to remove the capsule. So you will hold one end of the capsule and you will rotate in a circular motion, and this is known as capsulorhexis. And after this, so first you will do capsulotomy, then capsulorhexis. Then you need to separate this capsule from the nucleus. That is known as hydrodissection. Then in nucleus, you need to differentiate. So to differentiate this nucleus, whether you reached or not, we'll use this method, like where you will see this type of glow. So this glow, remember, this glow for this nucleus, it is what it is, this hydro delineation. Then you will break. Then you will break them. Then you will break with phaco probe. And once you break with the phaco probe, then what you will do, you will aspirate them. Once you aspirate them, you remove this internal part of the lens. So we'll keep up this lens, which is this posterior chamber intraocular lens. So if you see, there is multiple concentric rings. So it is what it is, the multifocal PCIOL. Means for this, you don't need to put one more glasses. Whereas for only if it is unifocal, then you need to give additional lenses. Fine. Additional glasses also. Fine. And this is this IOL insertion and finally draining. And for calculation of power, like how much this PCIOL, this posterior chamber IOL should be kept, will be calculated based on this SRK formula. SRK, now we are using SRK2 formula based on, especially on this axial length. Okay, remember axial length. Okay, and there may be few complications can be arisen because of this cataract surgeries. Okay, so one of the main complication is because of this unhygiene. Either if there is no unhygienic, if there is any unhygienic pre-op preparations, or if you didn't clean this eyelashes with this betadine, then it can cause to this deteriorate condition which is known as endophthalmitis. So they will ask you, what is the most important step in preventing this yearly endophthalmitis? The answer should be what? Cleaning this eyelashes with betadine. And on the later part, it can lead to this few other complications. After a few years, the patients will come and complain. There is a patient after cataract surgery. Patient after cataract surgery, then now complains of decrease in vision. Then you did an examination. There you will be able to see this type of opacifications. This is known as posterior capsular opacification. Fine. And in this posterior capsular opacification, also known as secondary cataract, it will be having two things. One is known as this Earl-Shrink pulse, like a pulse. It will be there. It is known as Earl-Shrink pulse. Fine. Then this type of rings, this is known as Somers ring. It's known as Somers ring. Okay, so Somers ring. So all of them, that is a part, are these are this a component seen in a case of posterior capsular opacification or secondary cataract. And next, one more complication, if you're able to see, there is this accumulation of fluids in between the layer of retina. So this is known as central, it is cystoid macular edema. Okay, there will be accumulation of this fluid in this layer of this retina, which is seen on this OCT. So will produces this type of hump. What is this? Cystoid macular edema. Just remember, okay, cystoid macular edema. And to treat this posterior capsular opacification, we'll use this laser for the surgery, which is known as Nd:YAG laser. We'll use this Nd:YAG laser. Remember, it will use this Nd:YAG laser for this surgery. Okay, and this is one of the most important part, which is this cataract, and one questions will be from this cataract. Fine. And next, if we move, it is what it is, this uveitis. If we see about this uveitis, this is the uvea. So this is this cornea, this is the iris, and this is the lens, and this is this uvea. And uvea will be having this parts of iris, ciliary body, and choroid plexus. On the choroid plexus, okay, and based on the place of the inflammation, this uveitis can be differentiated into anterior, intermediate, and posterior and panuveitis. All of these things, they are based on the location. For example, if it is iritis or irocyclitis, it is what it is, this anterior uveitis. Then ciliary body will be having two parts, pars plana and pars placata. If there is inflammation of this, it is known as pars planitis. Then this choroid, if there is posterior part which is this choroid getting inflamed, it is known as choroiditis. It is known as what? It is known as choroiditis. So these are the different parts of uveitis, and mostly they will be having this complaints of pain, redness, photophobia, and circumoral congestion. Means around the eye there will be this congestion of this eye. Okay, these are the usual complaints. And on evaluation of this anterior, mostly this is this pain sensitive area. So they will complain of more pain in anterior uveitis. So in this case of anterior uveitis, you can do examination. While doing examinations, you will able to see this type of arrangement of this precipitates. They are known as keratic precipitates. Keratic precipitates. And there will be this presence of cells. And there will be this presence of the cells. And when this neutrophils and the cells present in this anterior chamber, they will reflect their light. So that is what they will cause this flare. They will cause this flaring of this light. So in a case of anterior uveitis, you will see keratic precipitates and cells and flares. Okay, whereas the most significant one, it is the presence of cells. Okay, whereas the earliest you will see the flare. And the most common cause of this anterior uveitis is idiopathic more than this ankylosing spondylitis. Ankylosing spondylitis. Fine. And next, it means once this anterior uveitis gets healed, means there is this involvement of this iris. So once it gets healed, there will be formation of the scars. Once the formation of the scar, this leads to this type of irregularly shaped pupil, which is known as fest-tuned pupil. And next, sometimes after this inflammation, either this iris will be there, like this will be the iris, and anterior to the iris, there will be this anterior chamber, and posterior to the iris, it will be the lens. So in some cases, this can attach to the posterior of this iris, which is this lens, which causes this posterior synechiae, or it can cause attached to this anterior part, causing this anterior synechiae. So in a case of posterior synechiae formation, this posterior synechiae will cause this cataract. Whereas this anterior synechiae, I told you, anterior synechiae, it will block this angle of this anterior chamber. So if it blocks this angle of this anterior chamber, then it leads to this glaucoma. Fine, it is this glaucoma. Fine. Then in intermediate uveitis, you will be able to see there is this involvement of this pars plana. So it is the pars planitis and vitritis. So once there is involvement of this vitreous, if you see, it will lead to this lead to this haziness and causing this type of appearance, which is known as snow banking. Okay, which is known as snow banking, and this will be presenting as floaters. And one more thing about this anterior uveitis. In the case of anterior uveitis, you saw like this type of small precipitates, they are known as capes. Whereas if it is a large one present, they are known as mutton fat capes. They are classically seen in the case of granulomatous uveitis. Okay, for example, in the case of TB, in the case of syphilis, in the case of leprosy, it will be causing this granulomatous uveitis. Fine. And in posterior uveitis, it will be causing this chorioretinitis. I told you it will be causing this choroid, and it also causes involvement of the retina, which is known as chorioretinitis. Fine. And the drug of choice usually for this anterior part, it is the steroids, and adjuvant to this, there will be more pain. So we'll use atropine to provide this spasm. To relieve this spasm, we'll give this atropine. Okay. And we have one more ophthalmitis, which is known as sympathetic ophthalmitis. Like for example, there is a chiseler who was working with this chisel. and this foreign body has been scratched into this eye, and the scratched foreign body went into the choroid and it caused damage to the choroid. Once it caused damage to the choroid, this choroidal antigens will be released into the blood and antibodies will be produced against it. And once this antibodies comes and attacks this eye, okay, it will cause this other eye also will feel and will be having this choroidal antigen. So this antibodies will be produced against these two eyes, and this other eye will be sympathizes for it. So both eye will be affected. That is known as sympathetic ophthalmitis. And there you will see a nodules which is known as Dahlen-Fuchs nodules. You will see these nodules which is known as Dahlen-Fuchs nodule. Okay. And about this next part, which is this IOP measurement. Yeah, good Dr. Shanmas. And next about this IOP measurement. So we know the gold standard for this IOP measurement. It is what? It is this tonometer, which is known as Goldman applination tonometry. It's known as Goldman applination tonometry. And now it is being replaced by one more tonometry, but it is not in widely used. It is known as, which is more accurate than this Goldman, which can tell you, because in Goldman we need to assume, because there will be formation of this kind of inion. Okay, there will be formation of this inion. Okay, so whereas in a case of Pascal's, it will give you the proper reading and value. Okay, proper reading and value. So it is more better than Goldman. Yeah. My next one is this tonopen. This tonopen, it is used for this irregular cornea. Okay, if the cornea is not regular, for example, if there is any scarring of the cornea, if there is any opacity, after trachoma there is opacity, after vitamin A deficiency there was some xerosis, it leading to this irregular cornea. In such cases, we'll use this tonopen. Whereas we'll use this one more thing, which is known as rebound tonometer. For example, someone is having glaucoma, he want to test it by himself or herself. So in such scenario, we'll use this rebound tonometry. We'll use this, which tonometry? We'll use this rebound tonometry. Okay, rebound tonometry for self-use. And next, most commonly in hospitals, we use this type of tonometry, which is known as non-contact tonometry. We'll use, when you shoot this button, you will get some gush of air, and this air will find what is the level of this pressure. So this is known as non-contact tonometry. It is known as non-contact tonometry. Next, we'll move on to this next important topic, which is this glaucoma. And we know that different types of glaucoma, and the mainly one is this acute angle closure glaucoma and open angle glaucoma. Fine, angle closure glaucoma and open angle glaucoma. If you see initially, this open angle glaucoma, it is the most common one, and it is due to this blockage of this trabecular meshwork. Fine, and it is most common seen in a case of high myopia patients. Fine, and usually there will be these few conditions which will be associated. There will be increased intraocular pressure. There will be visual field changes will be seen in them because of this increased intraocular pressure. There will be visual changes. Why there is visual field changes? Because there will be a damage to this optic now. Okay. Now you say a child who is having these features of bull's eye. Okay, bull's eye. Okay, bull's eye, also known as ophthalmos. So it is a feature of congenital glaucoma. It is a feature of congenital glaucoma. Fine. In congenital glaucoma, there will be features of lacrimation, photophobia, and blepharospasm. Three will be there. Like because of this over large eye, means there will be always lacrimating, and he will be having this he will be having this photophobia to this light, and because of this he will be spasm to this light. So it is known as blepharospasm. So blepharospasm, photophobia, and lacrimations. All of these three things, they are classical for this congenital glaucoma. Then in the case of congenital, we'll see this striae, which is known as hat striae. So we'll see this striae, which is known as hat striae, and there will be deep anterior chamber. So in the case of congenital glaucoma, what we'll do? We'll do this thing which is known as trabeculectomy or trabeculotomy. Means we'll remove some part of this trabecular meshwork and will promote the aqueous flow, or else we'll remove more part and we'll put the graft. So that is known as trabeculotomy and trabeculectomy. And next, there's this type of glaucoma which mostly occurs during the night time. So during the night time or during the theaters, you are sitting and watching a movie. Okay, when you are sitting and watching a movie, when there is an interesting scene, it will be, your eyes will be in the mid-dilated state. And mid-dilated state, it will lead to this falling of this pupil and causes closure of this anterior angle of this anterior chamber. Once this angle of this anterior chamber closes, then the pressure inside the eye will be suddenly increased. Once there is this sudden increase in the pressure, then it leads to this pain in the eye. There will be a gastrointestinal symptoms like vomiting, nausea, and all of these things will be associated with this condition, which is known as acute angle closure glaucoma. And here the pressure may increase even up to 60 to 70 millimeter of Hg. Okay. Then here you will be able to see there is this mid dilated vertically oval pupil. Vertically oval pupil. Mid dilated vertically oval pupil will be seen in a case of angle closure glaucoma. Will be seen in a case of angle closure glaucoma. Fine. And here I told you the IOP will be high, and the treatment is what it is, this giving this mannitol and pilocarpine. So in a case of this, if it is occurs in the one eye, there is a high chances it can occur in the other eye. So we'll do prophylactic iridotomy in the other eye as well. So what we'll do, we'll create a chamber with this laser iridotomy, or else we can put few walls which is known as Ahmad-glaucoma wall, and express device, okay, to prevent this flow of this aqueous humor. Okay, they means this angle closure glaucoma, it is most common in a case of hypermetropes. This is most common in a case of hypermetropes, whereas open angle will be most commonly seen in a case of myopes. Okay, remember. Next, as I told you, there will be this optic nerve involvement. Because of this optic nerve involvement, what will be there? There will be a visual field changes. What are the visual field changes will you see? First one, what you will see, it is what it is known as paracentral scotoma. It is known as paracentral. It is the blind spot, and it is around the center. It is known as paracentral scotoma. And next one, it will be forming this type of scotoma where it is forming this small ring. So it will be this arcuate scotoma, and then there will be this nasal stepping will be there, and followed by this, there will be this small pace will be led. It is known as scrotal scotoma or sickle shaped scotoma, and then there will be this formation of two arch. It is known as double arcuate scotoma, and finally there will be this scotoma which is showing this tunnel shaped vision. Tunnel shaped vision will be there, and finally there will be complete loss of vision. There will be complete loss of vision. So these are the stages of this visual field defect. And we know to measure this, to know this visual field defect, we'll use which instrument? Yeah, guys, we use which instrument to know this visual field defect? We use perimetry. We'll use perimetry. Remember. Next, we'll see into the drugs which we use in a case of glaucoma. I told you, in a case of open angle glaucoma, we need to suddenly reduce the pressure. So in a case, we'll use mannitol. Whereas here, we need to use proper anti-glaucoma drugs. For example, here we'll use beta blockers. Okay, it will decreases the production. So we know, as we studied in Meniere's disease also, what there will be either increased production, there will be decreased production. Here also the same. Either there will be a more aqueous production or less excretion. So in such cases, either will decrease the formation by giving this beta blocker, and one more complication of this beta blocker, it is blocking this nasolacrimal duct. Fine. And there is one more drug which is this alpha receptor agonist. It will increases the drainage as well and decreases the formation. But side effect of it was, that is this CNS depression. And next is the carbonic anhydrase inhibitors like donzolamide and brinzolamide. Okay, and there are the most commonly used drug, it is this prostaglandin analog, which is this letinoprost, travoprost, and brivaprost. Usually, like there will be two mechanisms of this aqueous flow. One is known as what? One is known as trabecular flow, and another is known as uveoscleral flow. So this prostaglandins, they will increase this uveoscleral flows. Okay, remember. And we know prostaglandins will be increased during an inflammation. So they will be contraindicated in the case of uveitis. Fine, they will be contraindicated in the case of uveitis. Okay, and hyperosmotics like mannitol we can use it. And recently it is getting popularity, which is this rho kinase inhibitors like netazodil we are using recently, and it can lead to this condition which is known as vortex keratopathy. So vortex keratopathy, it is a side effect of this rho kinase inhibitors. This prostaglandin analogues can lead to a side effect which is known as heterochromia iridis. It causes different color of this iris, and also it causes this hypertrichosis over here. So there's this trichosis over this eyelashes. Remember. Next, we'll see few conditions. This is what, if you see this elastotic degeneration, this type of elastotic degeneration seen in a hot and humid climate, it is known as what? It is known as pterygium. And in pterygium, if there is iron deposition, if a line which is showing this iron deposition, it is known as Stokers line. Remember? And for this This may come and includes into our visual axis, and it can cause astigmatism. And the treatment of this is what? It is doing osteografting and putting mitomycin C. Like we'll do this conjunctival autograft and put mitomycin C. Remember, we'll do this, take this conjunctiva and put it here, and we'll put mitomycin C to prevent any adhesions. Fine. And there is one more condition which is similar to this pterygium, but it is yellow fatty deposit, fatty and calcium deposit. It is also seen in the hot, humid climates. It is known as what? It is known as pingucella. It is known as what? It is known as pingucella. It is known as pingucella. Okay. And now one surgery will use for this pterygium, which is known as pterygium extended resection followed by a extended conjunctival transplantation. So it is a simple transplantation only, but it is given an extensive name. Okay. And next we see these few important conditions. Okay. This includes the first one, which is this VKC, which is vernal keratoconjunctivitis. This VKC, which is also known as spring cataract, but it actually occurs in the summer days. It will actually occur in the summer days. Okay, it will be having this typical feature of this spots around this limb, which is known as Horner Taunter spots. This cobblestone papillae, and this type of ulcer, which is known as shield ulcer. So all of these things, they are this classical features of this vernal keratoconjunctivitis, and we know it is the type 1 hypersensitivity reaction. It is the type 1 hypersensitivity reactions. Usually in history they will give, there is a patient or adolescent patient who is presenting with features of ropey discharge with itching. Okay, with itching. On evaluation, you will be able to see this type of cobblestone papillae and Horner Taunter spots. You will think of vernal keratoconjunctivitis. Fine. Next, if we see, this is known as what? This is known as spectranullar conjunctivitis. It is known as spectranullar conjunctivitis. Fine. This spectranullar conjunctivitis, which is what? Which is this flicton. Okay, flicton. This is small nodule, right? It is the flicton. So it is the flicton. Remember, it is the flicton. And this spectranullar conjunctivitis, it is a type 4 hypersensitivity reaction. And in India, the most common cause of this spectranullar conjunctivitis, that is the tuberculosis. So to treat this spectranullar conjunctivitis, हम क्या देंगे? ATT, anti-tubercular therapy देंगे. Whereas in bold, the most common cause in bold, it is what? It is the Staph aureus. Staph aureus. बस इतना याद रखना. Next आगे बढ़ते हैं. Next disease, which is this trachoma. We know it is eliminated from India. Eliminated from India. Remember. And next, so there is high chance of being asked about it. Fine. This is due to this chlamydia infection of A, B, C. It is due to the infection of this chlamydia trachomatis of the species of A, B, and C. And in WHO classification, it is classified as Fisto. F-I-S-T-O. Fisto. That will be what? First one. Trachoma. It is Ma. It is Ma. माँ ने एक आर्ट बनाया. आर्ट मतलब कला बनाया. कौन सा कला? It is the art. So you will see this art lines here, and it is her who made it. It is the she or the her who made it. It is you. So trachoma is, it made a art. Okay, it made a art. What is the art? The art is made up of this sago grain follicles. So उसने साबूदाना की the sweet बनाए. Okay, remember. So it is the ma, which is trachoma, which made this art, which is exclusive by her, which is what? Which is this sabudana ki, means like it is the payasam kind of thing which she made. Okay, remember. So here you will be able to see this sago grain follicles, and then you will be able to see this type of scarring in this upper tarsal conjunctiva, which is known as arch line. Okay, and here you will be able to see this type of pits, which is known as Herbert pits. Yeah, the key. Yeah. Fine. And this is this fisto. Follicles, inflammation causing the scarring, and then S for inflammation causing the scarring, then this Herbert pits, then this tracheasis, means instead of like this eyelashes, it will be turned inward and will be causing rubbing of this eyes. So it is known as tracheasis. So it is the misdirection. It is the misdirection. Okay, and it will cause this opacity over this region. So you can see, right? It is the cornea. Here you will be able to see this whitish opacity. Usually it will be white, but here you will be able to see there is this opacity is there, this opacity is there. So this type of opacity will be seen in a case of trachoma. And in trachoma, we'll use this strategy, which is known as step strategy. क्या क्या करेंगे? Surgery करेंगे. Azithromycin, which is an antibiotics देंगे. Then we'll maintain this facial hygiene with cleaning of the eyelashes. Then we'll do this environmental modification. So safe surgery, antibiotics like azithromycin, F for facial hygiene, E for environmental management or environmental modification. Okay, this is about the trachoma. Next about this disease, which is due to this localized protrusion of this cornea. So if you see cornea, it will be like this, but here the cornea will become like this. So this is known as localized protrusion, especially due to the ectasia of this central part of this cornea. So it is what it is known as keratoconus. It is known as keratoconus. And what is the classical finding the patient will tell? The patient tells that he changes his glasses very frequently. So this is the frequent change in the glasses and difficulty vision even with glasses. And when you tell the patient to look down, he will able to see this type of cornea, which is known as what? Which is known as Munson's sign. Which is known as Munson's sign. Here you will able to see Vox striae. Here you will able to see which striae? You will able to see this is keratoconus, and looking downside it is looking like a V. So this is this keratoconus, and here you will able to see this Vox striae. Remember, it is the Vox striae. Remember. Next, it can lead to this irregular myopia and myopic astigmatism even. And to treat this condition, we can give this hard contact lens and one more therapy, which is known as C3R, which is known as collagen cross-linking with riboflavin. Collagen cross-linking with riboflavin. Okay, fine. Next about, we'll come to this corneal ulcer. In corneal ulcer, usually they will give the history. Like if it is a bacterial ulcer, they usually tell there is a contact lens users, and he or she doesn't remove this contact lens for a longer period of time. Okay, so this will be suggestive of an ischemia and leading to this corneal ulcer. And this corneal ulcer, we know the most common cause of corneal ulcer, it is what it is, this Pseudomonas. And if it is a bacterial ulcer, it will be having this well-defined margins. It will be having this well-defined margins, and along with this well-defined margins, sometimes it can be associated with this hypopyon and corneal staining. फिर आप क्या करोगे? You need to find the organism, right? You will do this corneal trapping and you will do the gram staining. Whereas you get a history of farmer with a history of trauma with this vegetative matter. There is a farmer with history of trauma with this vegetative matter, and this farmer with history of trauma with vegetative matter with the sign of less signs will be having this type of fuzzy margins, fuzzy or feathery margins. This fuzzy or feathery margins, along with this presence of satellite nodules, satellite lesions. It will be suggestive of fungal corneal ulcer. It will be fungal corneal ulcer. So in this case, we use this KOH mount for a staining. Fine. And next, if you are able to see this type of dendritic ulcers, it will be especially seen in a case of herpes simplex virus keratitis. Okay, herpes simplex virus keratitis. Okay, there are two types. Epithelial, it will cause dendritic ulcer and geographic ulcer. Fine. And there will be a stromal keratitis, which comes this disciform keratitis and endothelial keratitis. So epithelial will cause dendritic ulcer and geographic ulcer. Dendritic ulcer and geographic ulcer will be caused by this epithelial keratitis. So dendritic and geographic will be caused by this epithelial keratitis. Okay, it will be caused by this herpes simplex virus. Fine. And next, you saw a patient who is presented with this ring-shaped ulcer. Ring-shaped ulcer, and he is a contact lens user who washes his lens in tap water. So it is what it is. This is the diagnosis of amoebic keratitis, which is showing this ring-shaped ulcer. So in a case of acanthamoeba ulcer, we'll use PHMD as a treatment modality. Fine. And next, we'll see this next staining of conjunctiva. So in the case of the recent cases of dry eyes has been increased. So they will tend to ask this type of questions. So in a case of dry eyes, we'll stain the conjunctiva and see whether the patient is having dry eyes or not. Fine. So we'll use first stain, which is rose in color, which is known as rose Bengal stain. Next one, in case of any corneal trauma, अगर जो भी corneal trauma के पास होगा या corneal aberration के पास होगा, then we'll start with this stain, which is known as what? Fluorescent stain for corneal aberration. Okay. Next, if you're able to see this green dye, it is what it is. This Lesame green. It is the Lesame green. All of them, they will be used for this staining of conjunctiva. Then we'll use two tests. If you know this test, it is the Schimmer's test, and the same fluorescent test we use here, and it is the rose Bengal stain. And we'll use one more test, okay, to know like after how much time the tear is breaking up. So it is known as tear breakup It is not your breakup time, it is the tear breakup. Okay, it is a tear breakup time. Yeah, good, Dr. Mohit. It is the Schimmer's test previously. Fine. And next, we'll see this disease, which is this retinoblastoma. I told the most common presentation of this retinoblastoma, it is what? It is the leukocoria. And the condition which is being associated with this retinoblastoma, kya? It is this osteosarcoma. And we know we'll see this calcification and we'll able to see this type of central white or opaque one with this rosettes. If central white rosette, it is the true rosette, which is also known as what? Flux nerve intestinal rosettes. So based on the level of extension of this retinoblastoma, we will go either with small excision to the enucleation as well. Okay, so we'll do enucleation as well in later part if there is any more metastatic lesions. Okay, then this for this retinoblastoma, we'll use this chemotherapy method, which is this VEC, which includes vincristine, etoposide, and carboplatin. Vincristine, etoposide, and carboplatin. Vincristine, etoposide, and carboplatin. Remember. And next, if you see about this diabetes mellitus, we know in a case of diabetes, we need to screen them for this diabetic induced retinopathic changes. You know, in a case of type 2 diabetes mellitus, whenever see them for the first time, we need to tell them you should screen immediately. You should go to the screening immediately. Okay. And in a case of diabetes, if you see RB gene location, it is in the 13th chromosome. It is located in the 13th chromosome. Okay, especially 13p40. Right? Remember. Then, if you see this next diabetic retinopathy, there will be this initially this non-proliferative diabetic retinopathy. There will be presence of this microaneurysms, intraretinal hemorrhages caused by this rupture of this microaneurysms. Then there is a presence of this Dotten blood hemorrhages, and there will be this superficial flame-shaped hemorrhages. So most of them you need to remember about this hard exudates. Hard exudates, which are actually what they are, this actually lipids. So these are this hard exudates, which are actually lipids deposits, and there will be this presence of this microaneurysms. These are the two main features which you'll see in a case of non-proliferative diabetes mellitus. Okay, after seeing this non-proliferative diabetic retinopathy, it will progress into this proliferative diabetic retinopathy. In the case of proliferative diabetic retinopathy, there will be proliferation of this new blood vessels. New blood vessels. Okay, there will be proliferation of this new blood vessels, and because of this neovascularization, it can lead to this. Vitreous hemorrhage. It can lead to this vitreous hemorrhage. So in such cases, for preventive measures, we'll give anti-VEGF drugs like bevacizumab and ranibizumab. Whereas as a treatment modality, we'll do this thing which is known as PRP, also known as pan-retinal photocoagulations. We'll do in the case of proliferative diabetic retinopathy. Okay, bas itna hai that now. Then you need to know about this few spotters. If you're able to see this type of cherry red spot, and along with this sudden painless loss of vision, okay, it is seen in a case of CRAVO. Okay, it is seen in a case of CRAVO. Okay, whereas if you see this flash torpedo appearance, it will be seen in a case of CRVO, which is also known as 100-disc glaucoma, which can lead to 100-disc glaucoma. Okay, then this type of pizza pie appearance will be seen in a case of CMV retinitis, and it will occur at a level of CD count less than 50 in HIV positive patients. Okay, HIV positive patients. Okay, and this is the CRAVO, sudden painless severe decrease in the vision. The same for this sudden painless loss of vision along with this tomato plus splash appearance. Right. Next one, which is this visual field defect. If you see, means there will be initially, if at the level of nerve blockage, if at the level of nerve, if there is an injury, then it will be what? There will be the resulting in this monoocular blindness. It will be resulting into this monoocular blindness. Whereas next, whatever next to it, it will result into this both eye injuries. Fine. Like are both sides injuries. Fine. Next, if you see, this is this optic chiasma. If there is any damage at the level of optic chiasma, then it leads to this bitemporal hemianopia, also known as heteronymous hemianopia. Okay, then it is at the level of 2. If there is any other lesions next to it, it will be always homonymous. It will be always homonymous in nature. Okay, it will be, oh yeah, Mohit will, I'll tell you in once we complete it. Fine, don't worry. Okay, so it is Once after it is known as homonymous hemianopia. So if you see this optic tract, it will result in homonymous hemianopia. Fine. So whatever side is there, for example, see, this is the right side and this is the left side. So if there is a lesion at the right side, okay, it will lead to this left homonymous hemianopia. It will lead to this left homonymous hemianopia. And next, based on this radiations, there will be two radiations. There will be this temporal one, there will be temporal one, there will be parietal one. If it is parietal one, it will cause what? It will cause inferior quadrianopsia. Okay, if it is a parietal radiation damage, parietal radiation damage. Whereas if it is a temporal lobe or radiation damage, it will lead to this superior quadrianopsia, also known as pie in the sky. Whereas this one, it is known as pie in the floor. And next, if you see, there is a homonymous hemianopia, and along with this macula sparing. This macula sparing homonymous hemianopia, it is due to this at the level of occipital cortex. It is due to the damage at the level of occipital cortex, because occipital cortex will be supplied by these two arteries, PCA and MCA. And the central part of this macula, this cortex region which is receiving the supply from the macula, it will be getting supply from this two, this PCA and MCA. If this PCA gone also, then this macula area will be supplied by this MCA. That's why there is this macula sparing. Okay. Next, about this extraocular muscles, if you see this extraocular muscles, there are 7 extraocular muscles: levator palpebrae superioris, inferior rectus, superior rectus, middle rectus, lateral rectus, superior oblique, inferior oblique. Okay, 6 and levator palpebrae superioris. All of them will be supplied, means like most of them it will be supplied by this third cranial nerve, except superior oblique and lateral rectus. Superior oblique will be supplied by this fourth cranial nerve, whereas LR6, lateral rectus, will be supplied by this sixth cranial nerve. Will be supplied by this sixth cranial nerve. Okay, and if there is any damage to this nerve, it will result in this following conditions. For example, if there is damage to the sixth nerve palsy, then lateral rectus will be gone. So here the central gaze, here this side is normal, whereas this is deviated to medially. Okay, here this side, if you see, adduction is normal, whereas an abduction, the patient is unable to do abduction. So it is what? It is this damage to this sixth nerve palsy. Whereas in a case of sixth nerve palsy, the patient will be having these features of face turn to this affected side. The face will be turned to the affected side. Whereas in a case of third nerve palsy, if you see, means the third nerve palsy, if you see, there will be features of this one which is known as ptosis. Okay, there will be features of this ptosis. Why? Because this third nerve will supply this levator palpebrae superioris. So it will supply this levator palpebrae superioris. That's why there is a manifestation of this ptosis. Fine, and it will supply all the muscles except SO4. So it will be manifesting as eye in and face out, eye in and face out. So there will be feature of yes, eye in and face out position, eye in and face out. So the eyeball will be deviated to this opposite side. I guess told wrong. I will just check it and tell you. So in the case of third nerve palsy, you will be able to see this eye will be to the outside, because only this lateral rectus and superior oblique are acting on. Okay, so the eye will be positioned outside. So this is, and there will be associated ptosis. This is what? This is the classical feature of this third nerve palsy. Okay, this is this third nerve palsy. Now the eyeball will be deviated to this downwards and outwards because of the pull of superior oblique and this lateral rectus. Fine. And next one, just you know about this myopia, hypermetropia, and astigmatism. We know in myopia we'll use the divergent, which is this concave lens, whereas in hypermetropia we'll use convex lens. Whereas in astigmatism we'll use both cylindrical and spherical lens. Bas itne yaad rakho. Fine. Then there will be this, if there is any, in the case of hyperopia, if it is not corrected, if it is hypermetropia, if it is not corrected, then it will be leading to this convergent squint, whereas accommodative exotropia will be seen in the case of myopics. If it is not being corrected in child, it will lead to this accommodative exotropia, remember. Next, if you are able to see this painless swelling on the upper eyelid, it is what? It is the chalazion. Which is actually what? It is this chronic lipogranulomatous infections of this which gland? It is the chronic lipogranulomatous infection of this meibomian gland, and we know it is not painless. So in the cases of this, we can do two things. Either we can give steroids or we can do scoop it out. Okay, we can give steroids or we can do incision drainage with the use of this clamp, which is known as Elysian clamp, and this scoop, which is known as Elysian scoop. Remember this two. Then about this ocular trauma, which is known as what? Ocular trauma will be resulting in this all of the features, like ocular trauma will lead to this blowout fracture. We know in blowout fracture there will be this ball will be coming and hitting you. Okay, once it hits, it will push down below, mostly because there is a air filled maxillary cavity, leading to this fracture of this floor of the object. Remember, it is the fracture of the floor of the orbit causing this inferior rectus to trap. Once this inferior rectus traps, the one muscle is not functioning, so it leads to this double vision, also known as diplopia. So there will be a diplopia, there will be it while going, sometimes it will take up the nerve and go, so it will lead to this anesthesia over the region, and also once this eyeball content is going down, this eyeball will be looking like it went inside. So it will be presenting with three dye features. They are known as diplopia, infraorbital anesthesia, and enophthalmos. Okay, and along with this there is a trauma. Obviously they will be having this features of ecchymosis. Fine. And finally, this blunt injury, it can produce this rosette-shaped cataract. Rosette-shaped cataract, it is seen in a case of blunt injury. Whereas sunflower cataract, it will be seen in a case of Wilson's disease. Yeah. On X-ray, it will show this teardrops. Fine, teardrops. Then we'll see this iridolysis is nothing but it is this break of this iris, and it will cause this D-shaped pupil. D-shaped pupil. Okay. And next we'll move on to this lasers of this ophthalmology. If you see this laser, we already saw this NDAG laser where we'll use for this posterior capsulotomy, iridotomy, and vitreolysis. Fine. Whereas we use this double frequency NDAG. The frequency is 1064 here. It is half of this. So this type of frequency or doubled frequency NDAG will be used in a case of retinal photocoagulation and cyclophotocoagulation. Okay, retinal photocoagulation and cyclophotocoagulation will use double frequency NDAG. Argon laser will use for this trabeculoplasty. We used in a case of congenital glaucoma, right? So that is a trabeculoplasty. We'll use this argon laser. Fine. And the rest like iodoplasty, pupillomydriasis, and retinal photocoagulation. And diode laser will use for retinal photocoagulation. Most of them will use for retinal coagulation. And excimer laser, which is a argon but fluoride. It is not argon green, it is the argon fluoride laser which we use for this refractive surgeries. We will call them as LASIK, right? So LASIK surgery will use this excimer laser. Then FEM2 laser we use for this cataract surgery. We will call them as FEM2 laser assisted cataract surgery. It will call them as FEM2 laser assisted cataract surgery, and in LASIK also we can use this one. Okay, in LASIK also we can use this one. Fine. And that's it most of the cases, and we'll see just a few exercises and we'll bind it up. Fine. Middle rectus. So all the rectus, all the muscles of these extraocular muscles, it will be supplied by the third nerve. Only lateral rectus and superior oblique. Lateral rectus will be supplied by the sixth cranial nerve, whereas superior oblique it will be supplied by the fourth cranial nerve. Okay. Then there is a child who is presented with epiphoron discharge. So you will suspect of which disease? You will suspect of NLD obstruction. So in a case of initial NLD obstruction, what you will do? You will do this massage. Once you do this sax massage, mostly it will cure. If not, around 1 year, you will do this syringing and probing. You will do around 1 year syringing and probing. And if it is not yet resolved, then you will do this DCR surgery. And we know this DCR, after doing this DCR surgery, will make this opening into this middle meatus. Okay. Will make this opening into this middle meatus. Okay. And this is this endoscopic DCR pipe, actually, which is used to create a hole in this on this area. Fine. And the final slide, it is what it is this retinitis pigmentosa. Okay. In a case of retinitis pigmentosa, there will be a presence of this thin blood vessels along with this retinal pigmentations, and there will be a pale optic disc. Okay. And there is a pale optic disc. Okay. So just remember one thing. सपने देखना अच्छी बात है, लेकिन सपने के साथ सो जाना अच्छी बात नहीं. So the same thing, just only dream, just wake up with the same dream and just put your efforts, you will succeed in life, right? That's it from the ophthalmology part. I will see you tomorrow with same enthusiasm and I will be waiting for you. Have a good day and have a good revision and do PYQs. Thank you. Bye bye.